example, in lower and middle income countries, I would like to have over here Professor Tawn Mapen, who is a professor of geriatric medicine at University of Malaya, President of Malaysian Society of Geriatric Medicine, and Honorary Secretary of College of Malaysia. She received her undergraduate and postgraduate training at Nottingham and Newcastle in United Kingdom and returned to her home country of Malaysia to take up academic position with University of Malaya in 2011. She has worked tirelessly to build capacity both in research and clinical practice in geriatric medicine in Malaysia and actively contributes to human capacity. Over to you, Dr. Professor Tawn Mapen.
For giving me the honor to actually talk about geriatric medicine here in Pakistan. I'm really excited actually to be able to share with you some of the work that I've actually been doing for the past few years. Okay, so this started with a little editorial that I was invited to write by Professor Rowan Harwood, the previous editor of Age and Aging. We've now got a new editor, and he used to be my teacher in Nottingham University, and he asked me to write an editorial. Prior to this, I was actually more of a falls prevention researcher, but now suddenly I've been thrown into the limelight as a lower middle income country geriatrician, trying to push for more resources for lower middle income countries. Low and middle income countries. So this is my disclosure. I have received some honoraria as a speaker and panelist, and also expert panelist from quite a few companies. But what I'll be presenting is entirely my thought and is not influenced by any of them. Okay, so here we go. We know that more older people lived in less developed and least developed nations in this world than in the developed countries. So aging is no longer a problem with developed countries. It is actually a problem in developing nations. And what we're seeing in developing nations is that we are seeing accelerated population aging. I'll come to that in a little bit. So we have so much less time to prepare for population aging than those wealthy countries which currently are suffering from, we call it super-aged populations. So this graph actually shows, can I get anything working? Yeah, there we go. This graph actually shows kind of common causes of death throughout the world. And we know that in the developed world, non-communicable diseases have predominated for the longest ever time since history began, I think. But what we don't know so well is that lower middle income countries and upper middle income countries have a predominant of non-communicable diseases. And I think a lot of the conference today, the last few days, have emphasized the fact that in Pakistan, it's no longer a problem with infectious diseases. It's mainly a problem with non-communicable diseases. And only in the low-income countries do infectious diseases still play a part, or communicable diseases. Oops, it's kind of running away from me. Oops, coming back. But you can see that even in these countries, non-communicable diseases are playing a huge part. And this actually is a very important thing to remember when you talk about managing older people. Okay, so geriatric syndromes, we keep changing them, you know. We used to say the 5 I's, now it's the 4 M's. So I've decided to list a few things, and you can add a few more if you can think about them. So basically, what we're seeing a lot in older people is inappropriate prescribing. That's a current term, rather than polypharmacy, because necessary polypharmacy is just now one of the things. So we're seeing inappropriate prescribing is happening more and more in our older population. Healthcare-related harm, very closely linked with inappropriate prescribing, but it's more than that. Being admitted to hospital, having tubes put in, getting unnecessary treatment, suffering from falls in hospitals, pressure sores, delirium, all these are what we call healthcare-related harm. And the latest one is what we call deconditioning. So they go to hospital, they get put in bed, they go in walking, they come out in a wheelchair. or sometimes in a trolley. And then reduced mobility is what we often see. So the older, when I first started doing geriatric medicine, they used to say off legs. So, but now we no longer say that. We'll say reduced mobility. And there's a new word for it soon. I'll tell you at the end of the talk. And falls, that's my main area when I first started going to geriatric research. Falls. So falls is a really huge problem leading to hip fractures, loss of confidence, and institutionalization. Confusion, so it can be acute or it can be chronic, so it can present as a delirium, or it can be a dementia illness. Multimorbidity, so they tend to collect illnesses as time goes on. This is very relevant to non-communicable disorders. So even in middle-income countries, what you're seeing is that as they get older, they collect diseases such as hypertension, diabetes, and in fact, these diseases are even more prevalent than in high-income countries because of the lifestyle. So level of obesity now is actually a problem with middle-income countries, no longer as much of a problem in high-income countries. So even in these middle-income countries, the number of comorbidities actually are higher compared to the high-income countries. And frailty. Frailty actually means increased susceptibility to anything, to death, to hospitalization, to ill health, to falls, and it really reflects a lack of reserve in the older adult. So, as opposed to in high-income countries who have had many, many years to prepare for population aging, what we see in low to middle-income countries is that our people have shorter life expectancies, but they become disabled sooner. So they live longer with disability. And we also tend to we're quite proud of our filial piety culture, especially here in Asia and in Africa. Apparently it's not any different. And this level of arrogance that our adult children have to look after their older parents has led to a disabling culture. So the older person has this expectation. In Malaysia, we now kind of look at it through gritted teeth and say entitlement. These entitled older adults. So and they'll be say entitled children, isn't it? But now we actually go entitled older adults because they actually expect the adult children to care for them. And then we have increased comorbidities, as I mentioned earlier. So we still have the unfinished set. So infectious diseases are still more common in middle-income countries and, of course, much more common in low-income countries. But we now have this ongoing set of non-communicable disorders and this emerging set of what we call age-related disorders, which are dementia, arthritis, and a lot of other degenerative diseases. Many of them are neurological, but they're not confined to neurological diseases. And of course, being lower and middle income, we actually have resource constraints. And people in Pakistan will know this very well. There's a huge amount of international migration and urban migration because of economic reasons. And at the same time, we are very financially and human resource restricted. And if anything, political will is perhaps the greatest enemy of preparation for population aging in LMICs. So let's talk about Pakistan for a few minutes. So in Pakistan, fertility rate is going down like any other country in the world. And despite all the political issues, life expectancy is increasing, and the average woman born today in Pakistan expects to live up to 74 years, and the average man expects to live 68 years. So life expectancy is increasing. And this is what you get because of a reducing fertility rate and increased life expectancy. You will have a growing older population. The aging graph is here, and it doesn't look so bad because it's still more than 10%. But if you really look at it properly, the increase is actually by 100% over the space of 30 years. So it's actually a huge increase. And the population of Pakistan is huge. So when we actually talk about absolute numbers, you're going to have millions more older people every 5 to 10 years. And at the moment, Pakistan is having what we call a demographic dividend, because of reduced birth rate. So and population aging is still catching up a bit. Older population is catching up a bit. So you actually have an increase, a high number of people in the productive age group. So this is the time you prepare for population aging. You don't want to wait until you've lost the demographic dividend to actually prepare, because by that time it might not be possible. So when will Pakistan start aging? So these are all projected figures, of course. So Pakistan will start aging by 2050, and it will do this in the space of about 20 years. So remember, France aged over 100 years, and Sweden France aged over 125 years, and Sweden aged over 115 years, and the USA aged over 70 years. South Korea decided to do it in 17 years, and Pakistan is going to do it in 20 years, and you will start in 2050. So you have about 2 decades to start getting ready. And the question is whether Pakistan has the political will to get ready. So this is what will happen internationally. So we're looking at dementia now. The countries which are red are the ones that will have a percentage increase of dementia at the fastest rate. And you know where they are. It will be, unfortunately, Pakistan won't be as fast as that. Most of these countries will be in Africa. And Mongolia stands out as well. And so what we're doing is we're actually packing the world full of geriatricians in the countries where dementia is increasing the slowest, and the countries in which dementia increases the fastest will have the fewest number of geriatricians. And it was 10 years ago, but I haven't found anything more recent. This is a map of Africa with a number of geriatricians there. So the little red one up there is Tunisia. So Tunisia is like the Singapore of Asia, and it has like all the geriatricians in Africa live in Tunisia. But the rest of Africa are a little bit stuck, including South Africa. And the white ones are where we don't have any figures, and the blue ones are where they have no geriatricians. So in most countries in Africa, from the figures we had 10 years ago, there are no geriatricians. So how about Pakistan? Are there any geriatricians in Pakistan? Well, apparently, there is no dedicated geriatric care facility in the country, according to Dr. Shahid Malid in Pakistan, from the Pakistan Medical Association. And certainly, geriatric medicine is not a recognized specialty, so older people come under the care of internal medicine. But when you look at the United States of America, has 7,000 geriatricians, and this is actually a decrease in number, and they're desperate because they say, we can't recruit, because about 10 years ago they had 9,000 and 2,000 retired, but no new ones joined. So there are actually not enough geriatricians in the United States of America, where they have 7,000 geriatricians, and over 50% of them are international medical graduates. So you might ask, how many people of Pakistan origin currently work as geriatricians in the United States of America? Maybe some of them could come back and contribute a little bit. Okay, so I'm going to take a few minutes to talk about Malaysia as a LMIC, and we're going to do a little case study to look at the problems we have in Malaysia when it comes to meeting the needs of the healthcare needs of our older adults. So we've been trying for the last 2 decades to get more geriatricians, but will our internal physicians even consider becoming geriatricians? Well, most of them are put off by the low financial incentives in the private sector, because it's a procedural specialties that do well financially in the private sector. So it's enshrined in the Medical Act that procedures gets paid many, many hundred times more than consultations, even though one consultation in geriatrics is actually an hour. And you can do a hernia operation in 15 minutes, but a hernia operation is paid about 100 times more than a consultation. So to train as a geriatrician, there's a compulsory 6-month fellowship attachment internationally, and the whole training fellowship takes 3 years. And once they've gone somewhere else, to a developed country, when they come back to Malaysia, they can't apply what they learned. So it's almost like wasting their time, and they get very disgruntled, and some of them actually go back to those countries that they did their fellowship in to work there. Because when they turn up to a district hospital in Malaysia, they find that they have very little limited MDT input, and geriatricians work in teams, and they're not given dedicated geriatrics beds, so they're just going around being roving geriatricians. And there's good evidence to show that roving teams are worse than no team at all. So they get really frustrated about how they can actually put what they learn into practice in Malaysia. And as happens, there are more Malaysian diaspora working as geriatricians in the UK, Australia, and Singapore than there are geriatricians in Malaysia. So, and this is a little town, a little village actually, just north of Singapore. It's in the state of Johor. It's actually quite picturesque, and it's just somewhere here by the beach. So very, very pretty, near a tourist destination. So over the pandemic, I packed a bus full of medical students, bought a lot of PPEs and test kits, and we drove to this little village to do some data collection for research. And we found not a single younger person in that village. Every single one of the people living in that village was over the age of 60. And they had not seen their children or their grandchildren for 2 years because of the pandemic, because every one of their children worked in Singapore, and all their children and grandchildren lived in Singapore. So in Malaysia, we are pretty well endowed with advocacy group. This is not an exhaustive list, but they tend to fight each other, and they compete for message. They compete for the government attention, and they provide the government with mixed messages, which makes it very difficult to actually have a clear advocacy for any strict agendas. And there are 2 ministries that have been given the portfolio for older people. You would expect the Ministry of Health, but the Ministry of Health structure then parks the older person sector under the Family Health branch of the Family Health Development Division of the Ministry of Health, whereas geriatric medicine is a clinical service, and it's parked under internal medicine, which is parked under medical services. So the Family Health Division drives the policies, and the geriatricians actually look after the older persons. But all the welfare funding doesn't come to health. It goes to the Ministry of Women, Family and Community Development, and it's tiny. The budget is something like 10 billion ringgit for 2 million older adults. So 10 million ringgit would be about £1.5 billion compared to the healthcare budget, which is hundreds of billions of Malaysian ringgit. So our NGOs and our advocacy groups, very poor relations, limited intersectoral communication and understanding, no political will, and there's still this cultural belief of filial piety and the role of women in caring for older adults. And our government structure just does not lend to the delivery of geriatric services. And there's no ring-fence budget for geriatrics or dementia under the Ministry of Health, and a very small allocation for older persons under the Ministry of Welfare, Family and Community Development. So the Malaysian Society of Geriatric Medicine came up with a report to basically try and align everyone who's interested in geriatric medicine, not just to kind of push the government or nudge the government towards the right direction, with 8 strategic pillars to not just to grow the number of geriatricians, but to train allied health, to actually work with other specialties, to come up with specialists with special interest, family medicine with special interest, emergency physicians with special interest, develop community geriatric services, incorporate geriatrics in undergraduate and postgraduate training, and to actually look at including cognitive and comprehensive assessments in healthcare services, and particularly to bridge the gap between health and social care. And these are our global strategies, not just to upskill the workforce, to have dialogues with policymakers, to develop special interest groups, to develop toolkits, and to include everyone, all ethnic groups, particularly the original people of Malaysia, and to support, generate, and implement research. So, but the solutions for the future is actually ethical recruitment by high-income countries. Please don't just take them. Could we do something like exchange programs? I know you're running out of young people, but could we share a little bit more? And could the high-income countries contribute more to capacity building in LMICs? We need affordable solutions, and we need to actually involve. We need involvement in multinational research projects, because most of the research that's available available on geriatrics today is limited to lower middle income countries. So it looks like my time is up, so I will stop here. Thank you very much.